as I was just introduced, I work for FIND, which is the Foundation for Innovative New Diagnostics. And if you're not familiar with our organization, I'll spend a little bit of time walking you through. But as you can gather from our title, we're predominantly focused on diagnostics. And so everything that we do is really brought back to that central theme. And it's specifically in AMR, I think Usman made reference to Jim O'Neill's report where he called out the need for all prescriptions to be prefaced with a diagnostic before any antibiotics are given. That is a very big statement, and it's also a very heady statement because what type of diagnostic is needed is critical to understand. AMR isn't a single disease, it's a series of different presentations, and it's actually an outcome in health. And so how do we address that, and how do we tackle antimicrobial resistance at the global level, but also specifically within the regions that we're most interested in at FIND and supporting? So just a little background on FIND. We're over 190 people right now. We're headquartered in Geneva, but we have country offices across the world with a couple of additional ones that are coming online in the next year or two. And we're focused specifically on developing diagnostics that are meant to be deployed into the low resource settings. And so even though we are a globally focused entity, we are not really focused on developing diagnostics that would solely benefit the global north. And so it really brings a different lens to our work because what we end up having to focus on are really strategically placed tools that can impact patients within the healthcare system at the lowest cost possible, but being of the highest quality as well. Our mission, as you can see here, if you can see on the slides, is turning complex diagnostic challenges into simple solutions. And we started our focus really back about 13 years ago, focusing on tuberculosis. And of course, that really brought us back into the countries that had the biggest need and the biggest driver. And what we realized was we had to catalyze and we had to bridge between the patients that were seeking care and then what is the science that is going on between the industry developers, the regulatory, and the policy makers. How do we bridge that together to actually make something impactful for the patients in terms of their healthcare? And so we look at 4 different pillars. We look at catalyzing development. So we work very closely with industry partners to make sure that the technologies that they're developing are the ones that are actually needed. A lot of times there is a lot of effort that goes into this, but sometimes it's gone astray. And the technologies that are developed end up not being very relevant for very many healthcare settings. Either they're much too expensive or they're much too complex to be used in the healthcare settings that need them the most. We also look at guiding use and policy, so we work very closely with regulators, with the WHO, and with in-country partners to make sure that the data that we're gathering is impactful and provides evidence on how to use the diagnostics and how to implement them into the healthcare systems. We look at then accelerating access. So one of the things that we learned very early on was you can develop diagnostics and they can sadly sit on shelves and they may not actually get put into use. And so how do we work with the countries that need the diagnostics so that they understand how to put them in, implement them, and then make sure that they're a sustainable product that they can have access to year over year? And then we try to shape the agenda. And so this is obviously a very big part of our work here because diagnostics tends to be the third stepchild. So vaccines and drugs, rightfully so, get a lot of attention because they're the things that are actually saving patient lives. But without diagnostics, medicine is blind. And so how do you know what your patient needs, especially in the context of AMR, if there's no good diagnostic in place to inform the clinician about how to treat the patient? And so we work across several different pathogens or different disease areas, and the one that I'm leading is the emerging threats, which actually bridges 2 different topics, antimicrobial resistance, as well as pandemics or outbreak preparedness. So when we started to look at AMR about 2 years ago when I joined the foundation, we started to really try to understand what are the drivers of the emergence of resistance. Because as I mentioned, resistance is an outcome. And so what really is the factors that are contributing to these, especially looking at the countries that have the lowest possibility really for being able to implement the highest cost tests, which is what has traditionally been developed to address AMR because it really was coming out of the global north. And so the types of technologies that were implementable in the healthcare systems there aren't the ones that would be implementable within Africa. And so we started to look across several different countries and trying to understand from the patient care perspective and also from the clinician perspective, which technologies would be the most useful. And so we came up with 4 different areas that we thought diagnostics could actually impact the discussion around AMR. And so one of these is optimizing the use of antimicrobials. One of the things that we talk about quite a bit is reducing the use of antimicrobials, but I think fundamentally we all have to agree that antibiotics specifically, but all antimicrobials, are life-saving technologies, and we don't want to withhold them from a patient when they can benefit. But what we do want to make sure is that only the patients that need them are getting them. So we don't want to have the situation of over-treatment, which could be driving resistance. We also want to preserve new drugs. So as we invest heavily into the development of new antibiotics, how do we make sure that when they're implemented into scale, that we have the right types of gates and use technologies in place to make sure that we don't have rapid emergence of resistance. As was just said, it's inevitable, resistance will emerge, but how do we prolong that? And how do we also make sure that we use currently available antibiotics to the best of our abilities to treat patients and then stave off the early emergence of resistance to new drugs? And then specifically around surveillance, we felt that this was really a fundamental need within AMR. There's a critical gap in surveillance data coming out of Africa, Latin America, and Southeast Asia. And really it's because there's a lack of tools. There's a lack of fundamental capacity in terms of the diagnostics and the systems to be able to capture that data and then inform national policies about how to treat patients. And so we wanted to really look at specifically at what types of interventions we could put into place to strengthen that. And then we felt that it needs to be country-based evidence to guide policy change. We really aren't very interested in a one blanketed approach to AMR. We feel that on the health side, this really is a very specific topic around your healthcare systems, the way patients seek care in your country, how to actually implement these technologies in a way that will speak to the way your country actually offers healthcare to their patients. So I'll take you through a couple of our tactical and our actual ongoing projects on how we're addressing these topics. So right now we're working with what we're calling the Amr Diagnostic Use Accelerator. And this is specifically to look within countries about how to gather the evidence around the use of diagnostics. And here we're actually only looking at existing tools. We're not developing any additional new tools. How do we actually use very low cost and simple tools, but package that with clinical decision aids that would help doctors be able to walk through clinical algorithms, and then package that as well, bundle it with behavior change. So one of the biggest things I think we're facing with AMR is that the patient needs education about why they shouldn't be asking for or demanding antibiotics if they don't need them, but then also giving doctors the context to be able to say, I'm confident to not treat this patient with antibiotics based on all the clinical history, but then also hopefully by pulling in diagnostic technologies and results that would actually allow a clinician to then decide, I'm not going to treat with antibiotics because this patient perhaps doesn't need them due to a self-limiting viral infection. That is also a very big topic, and I'll talk about that in just a second. But our first wave, and this is really a platform that we're developing, where we're going to put in place the protocols and the pathways to be able to rapidly evaluate technologies, to be able to guide policy change within the individual country. But our first wave is specifically focused on patients and children and adolescents that are presenting with uncomplicated fever. And this really stems out of the discussion around malaria and the resistance that has arisen to antimalarials. What happened with the introduction of diagnostics for malaria is that patients that are presenting with fever are malaria negative tend to get treated with antibiotics. And it's really caused an uprising and an overtreatment of antibiotics. And so what we'd like to do is try to figure out those patients that are still in the healthcare system, because you still need to treat or diagnose, what types of technologies can we put in place with the behavior change component so doctors can feel confident that they don't need the antibiotics in the right settings. And the outcome is really to drive that behavior change, that component, but really to drive the conversation with the regulators in the countries about the data that we've generated so that they can change their policy and their guidelines on how to actually treat patients that are presenting with fever. The next waves of this, we still haven't decided, and it depends very much on the success of our first wave. But we would be very interested in looking, obviously, at the respiratory tract infections because it is such a big group of patients that are seeking care and getting antibiotics. So for another topic that we've focused on in the past year is stewardship of new antibiotics, and this is through the use of diagnostics. This is specifically a project that we're looking at the development of diagnostics for the treatment of gonorrhea patients. So it's a sexually transmitted infection that has high levels of resistance. And there's a new drug in development through the Global Antibiotic Research Development Partnership, which is GARD-P, also in Geneva. And they've invested in procuring the license for 140 countries on this new antibiotic. So in the next 5 years, this new antibiotic will become available throughout Africa and Latin America. And one of the things that we felt very strongly about was that it should not just go into generalized use for any patient presenting with, essentially, it's very, very nondescript symptoms is how it's treated right now. So there's what's called the syndromic patient management model, and patients present to the doctor and they complain of vaginal urethral discharge. And then what happens is the doctor says, well, it's probably either one of these 2 or 3 different sexually transmitted infections, so we're going to treat with a range of antibiotics. With the introduction of this new antibiotic, it would be put into use quite quickly, and we're cautious that we don't want to see emergence of resistance to happen too rapidly. And so with the change from the syndromic patient model to one that uses diagnostics, you would actually be able to gate which patients get the current treatment therapies or which ones would get escalated to this newer antibiotic. So we're driving right now to make sure that there's at least 1, if not 2, different kinds of diagnostics that are readily available at less than $5 a test before this new antibiotic is available and on the market. So follow-up to the conversation as well that we had around falsified or substandard and falsified medicines, which is also a contributor to patients using antibiotics that actually aren't effective, that could be driving resistance. One of the things that we're supporting is some work through the Fleming Fund and through the GAMREF project out of the UK, is looking at what types of technologies and tools could be implemented in countries and at what different points in the healthcare system could they be implemented so that you could rapidly find substandard or falsified medicines and then pull them out of the system and replace them with qualified and effective drugs. It's not the simplest procedure because this is a very big topic. There's a lot of regulators, there's a lot of different import mechanisms for antibiotics. But what we're looking at are really more simple tools that could be used at the pharmacy level so that pharmacists would be able to get control over what's on their shelves and what they're prescribing. But of course, this doesn't really drive into the accessing of antibiotics through non-traditional routes and through the less private sector, really. And so that's the next topic, I think, that still needs a lot of discussion about how to try and capture that driver, which is actually a pretty big driver, but very complicated. So empowering surveillance efforts, this is a topic that we're working on in a One Health approach. And we're doing this with several different partners right now, and it's a pretty complex project. But what we're really looking at is the fact that surveillance has to pull in information for AMR from different sectors, and the data that needs to be captured is very non-homogeneous. It's very different depending what sector is reporting and how they report. And so what we're trying to build for very specific pilot countries right now is a tailored and specific approach that we then hope we can take some general learnings from and be able to scale that into other countries that are interested in implementing. So we're developing an interoperability toolkit, which is really, and I'm sorry, but I'm not a tech person, but my tech people tell me it's a middleware solution that is able to speak to your field staff, your laboratory staff, and then up into your national surveillance systems, and then also tie your data back into international surveillance if you tie into WHO to the WHONet. But this interoperability toolkit, what it's really meant to do in simple terms that I understand is translate all this data into a common language that your governments and that your public health institutions can use to inform country resistance levels from a surveillance perspective. And it can pull data in from your health sector, from your animal health sector, your veterinary, or even your drug and use sector. And so that interoperability toolkit it's going to be an open sourced system that is customizable to your country's specific platforms that are already in use. We're also looking at developing smartphone RDT reading apps. So there's a lot of very simple technologies that are on the market for different tools to be able to diagnose malaria and HIV. But one of the things that's lacking is a very rapid way of uploading that information. And what happens is there's still a lot of paper-based transcription. So we're also developing an open sourced RDT reading app that would be available on a smartphone so that you'd be able to capture that information, automatically upload it into your interoperability toolkit, into that middleware system that would then feed your national surveillance information. And you would have real-time access to your field data to be able to understand what's happening at the national level. And then the third thing is the mobile devices. So these are really electronic clinical decision aid tools, and this is taking current algorithms that tend to be quite paper-based for clinicians and moving them into the electronic age and giving doctors tools that are able to very quickly walk them through the different signs and symptoms the patients are presenting with, but also input the results from the diagnostic test to be able to help guide therapy, and then be able to capture that in terms of did the doctor decide to prescribe an antibiotic? If so, what antibiotic was prescribed? And then we can actually get a little bit more depth into what are our usage rates on antibiotics, in what types of situations and what types of presentations does the antibiotic seem to be most frequently prescribed. And again, this is to feed back up into your national public health institutes to be able to give you a better view to what's happening on the ground and how that's really impacting you at a national level. And so right now we have tailored in-country pilots going. And as I mentioned before, we're very focused at making sure the solutions that we implement are particular to the countries. We don't feel that every country is the same. We're trying to build standardized frameworks that are replicable but tailorable to the country. And so as an example, one of the first pilots that we're working very closely with and has been extremely informative as a partner, and this is key because all of our work is done in partnership with the countries, is the Zambia National Public Health Institute. And the information that we've been able to get about how this type of technology and this kind of intervention would be used in the country is allowing us to really make sure that we shape the fundamental components of this work so that it is replicable in other countries as quickly as possible. We also follow target product profile development, so we make sure that we go through a transparent and very rigorous process to be able to set out any standards that we're expecting from any of the development projects that we're implementing. And so for these projects specifically, we're working under an open source model. And then we're also making sure that the developers of the apps are tied into the pilot project so that they can get some feedback very quickly from the countries about how to go back and tailor their products so that they're actually more amenable to implementation. So just to say thank you to our funding partners and our in-country partners, but one of the things I just wanted to very quickly mention was that there is a fragmented response to AMR, and it is what it does is it tends to defocus the conversation, and I think this was something that Guzman brought up. We really need to understand what the agenda is for AMR, specifically in the Africa and some of the Latin American areas, because the conversation that's happening in the global north is not necessarily the same one that applies. And we really have to understand what the major drivers are, and I think the environmental contamination driver is such a major contribution that it really needs a lot of focus. However, obviously, as we're diagnostics, we will focus on the development of diagnostics as best we can. But without a consorted and a consolidated view to how to tackle antimicrobial resistance, I think what's happening is there's a very fragmented approach, and it probably dilutes a lot of the funding dollars that are available. And so we have very incremental change that is going to come until we sort of really table this at a national and international level and get the voice of the countries in Africa specifically telling us what is the most impactful types of interventions for you in your nations so that we can make sure that those are prioritized globally. So, thank you.